management of newly diagnosed advanced stage disease ovary. So cytoreduction. Although the term optimal cytoreduction has been used throughout the years to represent the goal of surgery to leave behind less than 1 to 2 centimeter of the tumor volume, the modern school of thought mandates the goal of cytoreduction surgery is to leave behind no gross residual disease like R0 or complete resection. Interestingly, the first evidence that cytoreductive surgery impacts survival can be found in 1973 report of Margat et al. On the survival advantage conferred by extensive disease resection in pediatric patients in Africa with the abdominal Burkitt lymphoma. And this was followed by the landmark study of Griffiths from 1974, which the surgeon reported that among 102 consecutive cases of advanced ovarian cancer patients in whom residual disease greater than 1.5 centimeter in the maximum diameter was left in the abdominal cavity had all died from the disease within 2 years, compared with the 20% 2-year survival rate afforded by the residual tumor of less than 1.5 centimeter. And the watershed event occurred in 2002 when Brislow et al. Performed a meta-analysis of 81 ovarian cohorts treated with platinum-based chemotherapy and demonstrated that the most important determinant of survival was maximum cytoreduction, with each 10% increase in tumor resection associated with 5.5% increase in the median survival. The primary debulking may require many hours of operative time and be associated with multivisceral resection, packed red cell transfusion, admission to the intensive care unit with cardiac monitoring, and even in the most experienced hand significant post-operative sequelae. However, the outcome of the surgical approach in terms of residual disease remains the most important prognostic factor for survival. In 2017, Harter et al. Reported on lymphadenectomy in ovarian neoplasm Lion study. Patients who underwent optimal cytoreduction and had clinically negative lymph nodes were randomized to intraoperatively undergo final lymphadenectomy versus no lymphadenectomy, and the study primary endpoint of overall survival was not met. That is median 66 months in the lymphadenectomy arm and 69 months in the no lymphadenectomy arm. But the post-operative morbidity mortality were significantly higher in lymphadenectomy arm, indicating that systemic lymphadenectomy of clinically negative lymph nodes in women who have undergone complete resection should be omitted. And for primary disease, surgery can be performed upfront or after 3 to 4 hours of neoadjuvant chemotherapy. For patients whom remission or cure is highly likely, surgery can be palliative like small bowel resection or ileostomy for obstruction or gastric tube placement. So in the United States, more gynec oncologists perform surgery prior to chemotherapy and use neoadjuvant chemotherapy followed by interval cytoreduction and post-operative chemotherapy for those who present with more seems to be unresectable. And for patients whom debilitated medical condition precludes their candidacy for upfront resection. Patients with remission who ultimately experience recurrence may also be candidate for additional cytoreductive surgery or secondary debulking. Ideally, such patients should have a prolonged disease-free interval, remission lasting more than 12 months, have small volume or isolated recurrent disease as opposed to widespread carcinomatosis, and be medically optimized to undergo secondary debulking. Following the same general guidelines, tertiary cytoreduction may also be possible. Irrespective of surgery is positioned in the disease course, all visible tumors should be resected. Now, what is Lion? Lion is a randomized trial to evaluate systemic pelvic and para-aortic lymphadenectomy in 647 women with FIGO stage 2V4 ovarian cancer who had undergone macroscopic complete resection and had normal appearing lymph nodes both preoperatively and intraoperatively. Randomization to lymphadenectomy to no lymphadenectomy occur intraoperatively following complete cytoreductive surgery. The median PFS was 25.5 months in both the groups, and median OS primary endpoint was 69.2 months in no lymphadenectomy group and 65.5% in the lymphadenectomy group. Importantly, serious post-operative complications were higher in the lymphadenectomy cohort. A repeat laparotomy 12.4 versus 6.5, and mortality within 60 days after surgery 33.1% versus 0.9%. Another Lion was recommended assessing lymph node using preoperative imaging modalities together with the intraoperative inspection and palpation, and if lymph nodes are not enlarged among patients with advanced disease who will require adjuvant therapy, they should not be systematically removed following complete resection of visible disease. So what is platinum taxane based chemotherapy? In this table, systemic chemotherapy and targeted therapy regimens used in the management of newly diagnosed and recurrent ovarian cancer. The use of platinum taxane based chemotherapy is the gold standard for adjuvant treatment for advanced stage epithelial ovarian cancer. Although these drugs are used for all the advanced stage epithelial ovarian cancer, they are probably the most active in high grade serous and undifferentiated adenocarcinoma. And in 1996, McCurry et al. Reported the GOG protocol of 0111, the phase 3 randomized trial comparing cisplatin 75 mg per meter square and with cyclophosphamide 750 mg per meter square or paclitaxel 135 mg per meter square over 24 hours. And the patients with advanced disease with residual disease larger than 1 centimeter after surgery. Among 386 patients treated in the study, cisplatin paclitaxel arm versus cisplatin cyclophosphamide arm, there was significant improvement in both the PFS and OS. And GOG Protocol 158 was the phase 3 non-inferiority trial designed to test the efficacy and tolerability of substitution of carboplatin for cisplatin in combination with paclitaxel for advanced epithelial ovarian cancer. Gastrointestinal, renal, metabolic toxicity grade for leukopenia, they were more frequently in cisplatin containing arm, whereas grade 2 or higher thrombocytopenia was more common in the carboplatin containing. Neurological toxicity was similar in both because carboplatin plus paclitaxel resulted in less toxicity, was easier to administer, was not inferior to cisplatin or plus paclitaxel. Combination of carboplatin with paclitaxel emerged as the standard of care for advanced epithelial ovarian cancer. This combination also used for adjuvant therapy for high risk early stage FIGO stage 1A, 1B, grade 3, stage 1C, any grade, all clear cell sarcoma and carcinoma and completely resected stage 2. And this combination are given on the 21-day schedule for a total of 6 to 8 cycles. And the Scottish randomized trial of in ovarian cancer, that is SCOT ROC, phase 3 randomized non-inferiority trial evaluated the efficacy and tolerability of substitution of docetaxel for paclitaxel when combined with the carboplatin in FIGO stage 1C to 4 ovarian cancer. At a median follow-up of 23 months, both had similar PFS, OS, objective tumor of CA 125 response rate. Docetaxel carboplatin arm was associated with substantially less overall and grade 2 or higher neurotoxicity than paclitaxel carboplatin. Docetaxel carboplatin was associated with a significantly more grade 3 for neutropenia and neutropenic complication, and based on this result, combination of docetaxel carboplatin has become accepted alternative for frontline regimen, especially for patients with pre-existing neutropathy like in diabetic neutropathy.